Welcome everyone for the class on Resuscitation. So we'll be talking continuation of the last class. So it is a part 2 of the Resuscitation. So here we'll be mainly talking about shock. After shock, we'll be talking about mainly about allergic reactions, which includes anaphylaxis, anaphylactoid reaction, urticaria, and angioedema. Coming to the shock. Vaguely, most of us clinically practice shock as whenever there is a systolic blood pressure of less than 90 millimoles of mercury. But if you go according to the textbooks, it is loosely defined as inadequate oxygen supply, where it is not able to meet the demand. The oxygen delivery is less compared to the oxygen demand of the tissue. Then we call it as a shock. Whenever, especially the peripheral tissues, for example, skeletal muscle, receives oxygen level less than what it is required, then it undergoes a metabolism known as an aerobic metabolism. So this is from your biochemistry, from your first year of medical college. If you remember, it is an anaerobic metabolism which produces lactic acid. So most of the time when the patient is in shock, ends up having lactic acidosis. That is, lactic acid is accumulating, resulting in low pH levels, that is metabolic acidosis. So this metabolism is anaerobic metabolism resulting in accumulation of lactic acid, resulting in low pH. For all practical purposes and for your MCQ questions for MRCAM exams, systolic blood pressure will take it less than 90 millimoles of mercury. There are various classifications. The broad classification is there might be hypovolemic shock where there is loss of intravascular volume. It might be due to an hemorrhage. It might be due to an gastroenteritis. It might be due to an diabetic ketoacidosis, or it might be due to burns. Distributive shock is where there is third spacing of the fluids. That is, fluid is getting accumulated in intercellular spaces. It might be because of sepsis, neurogenic shock, or anaphylactic shock or anaphylactoid shock. Obstructive shock. There is an obstructive to outflow of cardiac outflow of blood from the left ventricle. It might be due to an pulmonary emboli, where there is an obstruction to the outflow of the blood from right ventricle. It might be due to an tension pneumothorax, where there is obstruction to the outflow from left ventricle, cardiac tamponade, similar pathology, or acute obstruction in any one of the major veins like inferior vena cava or superior vena cava. It might be due to a cardiogenic shock, where the ability of the cardiac muscles to compress, or the ability of the cardiac muscle to pump the blood decreases drastically. It might be due to various arrhythmias or late sepsis, which causes negative inotropic effect, or it might be due to an MI, cardiac contusions, overdoses like beta blocker overdose, or complete heart block. There are few clues you can pick up whenever the patient is in shock. From the history, you can guess what is the probable cause is. If the pain is radiating to the testis, especially in elderly person, don't think it is an it is not always an ureteric calculi. It can be an AAA, which stands for abdominal aortic aneurysm. So always think of an abdominal aortic aneurysm, that is AAA. Whenever there is pain radiating to the testis, usually classically they present with flank pain radiating into the groin region. Don't think it is an ureteric calculi in an elderly patient. Chest pain radiating to the back will be aortic dissection. Thoracic part of the aorta is getting dissected here. Onset with food, acute rapid onset anaphylaxis. History of taking steroids because of rheumatoid arthritis or because of asthma, and abruptly they're stopping it for any reason, can trigger an Addison's crisis. Muffled heart sounds, especially with hypotension and engorged neck pain, there is a triad what we commonly see in cardiac tamponade. Priapism with an injury to your spinal cord, neurogenic shock you can think about. Usually injuries will be above the T12 level. Unequal radial pulses, again aortic dissection you're thinking about. Distended neck vessels with hypertension, no muffled heart sounds, decreased air entry on the affected side will be tension pneumothorax. Sweet smelling breath along with an acidosis with significant ketones and significant blood sugar levels, or a known diabetic, then you're thinking about diabetic ketoacidosis. That briefly we are touching about shock. in shock, we will be again discussing like a neurogenic shock, and a trauma case we'll be again discussing the treatment persistent to that. Hemorrhagic shock we'll be again discussing in trauma. So in relevant chapters, we'll be again touching upon the shock in relevant topics. This is a brief overview of the shock. Now we are getting into anaphylaxis. This is very important. One question, if not two, will appear in the exam. So everyone RCAM wants to know about anaphylaxis. They want you to know how the algorithm goes about, how to give an IM adrenaline, what's the dose of it, and what is refractory shock. All those parameters needs to be known by any physician who is practicing in UK. That's the reason they test you heavily in RCAM exams. Coming to anaphylaxis. Anaphylaxis is basically an allergic reaction. A severe allergic reaction or a life-threatening allergic reaction is known as anaphylaxis. How do you approach? You approach according to airway, breathing, circulation, disability, and exposure. In this, if you can pick up, it is because of anaphylaxis. If the patient says, I just took a food and it ended up, then the first step will be to remove the trigger if any trigger is there. For example, a bee sting is present on the skin, just remove the bee sting. If it's having a food and still the chewed food particles are in the mouth, you can remove those particles. Most of the time, the trigger will already been removed by the time they have come to the emergency department. The first step or the first medication you're giving is IM, that is intramuscular adrenaline you will be giving to the anterolateral aspect. The position is very important, and make sure the patient is at least sitting or he's in lying position. Ideally, he should be in lying position, if not in sitting position. IM adrenaline needs to be given for any patient who is suspected to have an anaphylaxis. You need not get any investigation to diagnose an anaphylaxis. Anaphylaxis is a clinical diagnosis, so no investigation is required at all. Once you are given IM adrenaline, you wait for 5 minutes. In this 5 minutes, you are basically reassessing A, B, C, D, E, and making sure if any interventions, like if required in airway and breathing, if oxygen is required, you're giving oxygen. So those interventions you're doing. Once 5 minutes is done, you will see whether the patient is improved or not. If the patient is not improved, you will be giving second dose of adrenaline. Here you are given first dose, then you are giving the second dose of adrenaline. Again, you wait for 5 minutes. After second dose of adrenaline, if the patient persists to be in anaphylaxis or anaphylactic shock, that's when we label them as refractory anaphylaxis. Refractory anaphylaxis needs to be treated with adrenaline infusion. So the next step after the second dose of IM adrenaline is starting on adrenaline infusion. You need not remember the dosing of adrenaline infusion. You just follow the local protocol. So you need not remember what is mentioned here. It is obvious that to start an adrenaline infusion or to start any infusion, it takes time. You need to load it, then you need to connect it to an equipment, then connect it to an IV line, then start it. In meantime, when you're connecting, you can give repeated doses of IM adrenaline. Okay, you can give every 5 minutes, you can keep repeating IM adrenaline till adrenaline infusion has been started. If the patient, then what you're doing in the meantime, okay, you've started the adrenaline infusion. Now what you're supposed to do? Assess the airway. So we are repeating the assessment here. Assess the airway. If there is a partial obstruction, that means if for example, if the patient is having stridor, you can give adrenaline naps. If there is a total upper airway obstruction, then you might have to intubate following the difficult airway algorithm, which we'll be studying in coming up classes. What about breathing? If there are breathing efforts and the patient is having wheeze, then usually you treat it with salbutamol and ipratropium bromide, basically bronchodilators. The wheeze is because of bronchoconstriction. You want to dilate it by giving either salbutamol or ipratropium bromide. What if there is no ventilation at all? Apneic, there is no respiratory efforts at all. That's when you need to bag mask ventilate and consider tracheal intubation in these patients. Coming to the circulation, if the patient is hypotensive, resuscitate them with fluids. Okay, this is a distributive shock what you're having, anaphylaxis comes under distributed shock. So you're treating with fluids. In adults, we give it around 500 ml of boluses, and you keep repeating the boluses till the blood pressure increases or the patient is going into fluid overload. In children, it's 10 ml per kg. As we studied in wet flags, it remains 10 ml per kg in all possible acute situations in pediatric age group. Solutions, usually normal saline or Hartmann can be used. Those are the crystalloid solution, what is preferred. This much you need to remember. If at all, if the patient is still in shock after adrenaline infusion, after all these interventions, then you can consider other inotropes which can be given. Again, they'll not test you beyond this level. This should be sufficient for exam point of view. You can start adrenaline with noradrenaline or vasopressin. Those kind of drugs can be started. If the patient is on beta blockers, if the patient is on beta blockers, adrenaline effects might not be that great. This the reason we usually tend to give an glucagon. Okay, so consider all these parameters. This is very important from exam point of view. So you need to remember this. Coming to doses, this is also important. You need to remember these doses. In adults or children who are more than 12 years of age, 0.5 mg. In 6 to 12 years age group, 0.3 mg. 6 months to 6 years is 0.15. So you can see here, it is half of this age group. Then less than 6 months is 100 to 150 mics mics you will be giving. So depending on this, the dosing changes. Depending on the age, dosing changes. Questions have appeared on different ages. What was the dose to be given? So it is important. IV fluids, I have already mentioned here, is the IV fluids is the same thing. It's mentioned here again. What are the investigations you need to get? As I told you, it's a clinical diagnosis. No investigation is required. But you can get a mast cell trip test as soon as possible after 1 to 2 hours and 24 hours. You need to take 3 samples at 3 different timings. This increased mast cell tryptase levels will help you to label this patient definitely that this patient had an anaphylactic shock. If they are on beta blockers, plan giving glucagon as told earlier. Observations, I'll discuss more about observations after discussing about biphasic reaction. I'll get back to the observation. Biphasic reaction, what is biphasic reaction? The thing is, the patient who has anaphylaxis can have a biphasic reaction, which means after a few hours, he can have one more anaphylaxis. This anaphylaxis doesn't require any trigger at all, which is termed as biphasic reactions. So this is the reason we kind of admit these patients for observation. What are the risk factors for biphasic reaction? Again, it is important to said previously. More severe initial presentation of anaphylaxis. This means the patient is in severe shock, requires an oxygen or if not intubation. More than 1 dose of adrenaline IM is required. Delay in adrenaline administration. For example, for some reason you didn't have adrenaline, or some junior was seeing he has not given, for some reason there was a delay beyond 30 minutes. Then we consider as a delay in administration of adrenaline. That also is increased risk for biphasic reaction. History of previous biphasic reaction itself is a risk factor for biphasic reaction. That's why we need to admit this patient for observation. So how much time they should be kept in the emergency department, or they should be admitted in the hospital for? You can just keep it for 2 hours with patients with anaphylaxis if there is a good response for the first dose of adrenaline and it is given very quickly within 5 minutes, and the patient is back to completely normal self. That is complete resolution of the symptoms. Patient has an EpiPen with him, so you need not prescribe him. He already has an EpiPen with him, and there is a responsible adult with him who can follow up, who can be with him, and if required can bring back to the emergency department. So there should be a responsible adult who can bring back this individual to emergency department if required. When do we observe for minimum of 6 hours? We observe for minimum of 6 hours if there is a previous history of biphasic reaction or 2 doses of IM adrenaline is required. We observe minimum of 12 hours where there is a severe reaction where more than 2 doses of adrenaline required, or the patient has an underlying respiratory disorders like an asthma, COPD, or there is a continuing possibility of absorption of absorption of allergen. For example, a sustained release tablet they have taken, which has caused an anaphylactic reaction. Or a patient is presented at a night time and you feel it is unsafe to discharge him because there is no one to take care of him at home. Or patient is in an area, basically he's going to a rural place where there is no help, the help can't reach rapidly within few minutes, then you keep him in the hospital and keep in observation for a longer duration, that is minimum of 12 hours. All these patients, you need to make sure that you prescribe an EpiPen. That is nothing but adrenaline auto injector, that is preloaded adrenaline. So, and you need to explain how to use it. If at all is this recurs again, they can do it. Only in the cases where you can avoid the exposure, for example, they know this particular drug itself is causing, then you can avoid prescribing an EpiPen, that is preloaded adrenaline syringe. Or or this patient, for example, had a certain food and you can avoid it, then you can think of avoiding it. Otherwise, most of them end up getting an EpiPen, that is nothing but preloaded adrenaline. What are the common causes for anaphylaxis? Common causes are peanuts, tree nuts, or cow's milk. Remember this, they might test you on medications or antibiotics, especially penicillin and cephalosporin, neuromuscular blocking agents like succinylcholine, contrast media, what you use it for an contrast CT scan, or NSAIDs like an ibuprofen you can talk about, or brufen, any ibuprofen or ketorolac, any of the NSAIDs we are talking about here. As we are talking about anaphylaxis, what is anaphylactoid reaction? It is very much similar to anaphylaxis. The treatment also remains similar to anaphylaxis. The main difference here is it is not IgE mediated. That means it doesn't require an first exposure to antigen. In anaphylaxis, it is always required and first exposure to antigen. It's the second exposure where it is where your system reacts very abruptly, causing the anaphylaxis. Here, there is not at all required for an antigen exposure. In the first episode itself, it can trigger an anaphylactic reaction. Anaphylactic reaction, it is usually the second time trigger and it is IgE mediated. These are the examples, and these are the examples for anaphylactic. These are the examples for anaphylactic reaction. Both are treated similarly. There is nothing much difference. The only difference is it is not IgE mediated, and this doesn't require and it doesn't require and second exposure can cause in the first exposure itself. Anaphylactic reaction, it requires re-exposure to the antigen to causing and shock. Before we go to angioedema, anyone has any questions can ask me regarding anaphylaxis or anaphylactic reaction or biphasic reaction or refractory anaphylaxis.
Doctor, يعني in anaphylactoid, this one after the contrast, the patient can have an allergy without to expose, يعني it mean after many days, ولا?
No, it means usually in anaphylaxis, what happens? We'll take a contrast example. In first contrast, he'll be having very mild reaction. He had a CT contrast first time, then he had a mild reaction. Second time you're using the same contrast, that's when it will develop a very severe reaction resulting in anaphylactic reaction or anaphylactic shock. Anaphylactic shock is the first time itself exposure to the contrast, they have an anaphylactic shock or anaphylactic shock, we call it, sorry, anaphylactic shock with the first exposure itself because it is not IgE mediated.
Sir, why it is intramuscular is chosen? If the patient is admitted in case in the hospital, still the intramuscular will be the first route of administration instead of intravenous, or intravenous can be the first route, sir?
It is always recommended to give intramuscular adrenaline because we are giving 1:1000 dilution here. The dilution is important, 1:1000 dilution. If you see the literature and if you see the research guidance, if you are experienced enough to give IV, then you can give it because the heart muscle reacts abruptly. You can go in tachyarrhythmias with adrenaline giving IV. If you're not experienced, or for most of the individuals, they recommend giving IM. That's why their algorithm has IM instead of IV. And directly they have advised for an infusion, not giving IV bolus. If you're planning to give an IV bolus, you need to be really experienced. You must have given before in hand, then you can plan giving it IV bolus.
Sir, what
For
experience?
exam purpose, it's always you're giving IM, not IV.
Sir, for IV, what experience is needed, sir? What do you mean with experience?
Basically, you have been working in intensive care unit previously. You have witnessed someone giving IV. You know how it acts. You know the mechanism of action, what it has. If at all, if there are adverse effects, you know how to treat it. So all those competencies you have, usually you get the competencies signed in UK. If you have a signed competencies, then you can justify. If something goes wrong, you will be liable to sue. You will be liable for court and coroner, and you'll be liable for a case against you. That's the reason they advise for IM unless you have a competency signed for that.
Doctor, sorry, I not understand the difference between the anaphylactic and the another one, the one slide before. Anaphylactoid. No, the last one. Yeah, this one.
So basically, there should be a re-exposure to the antigen. If there is no re-exposure, only first exposure is anaphylactide. Re-exposure is anaphylactic reaction. Rest everything remains the same.
Yani the same person who's taking antibiotic the first time, it's anaphylactic. If he use again, it will anaphylactoid.
See, for example, if you're taking an penicillin, first time you take it, you had a mild reaction. Mild reactions, we don't call it as an anaphylactic shock. Mild reaction, we just call it as an allergic reaction, what you had. Okay, and we don't call it as an anaphylactide reaction also. Second time you are taken and you ended up in a shock requiring an IM adrenaline, so it is severely affected, then we call it as an anaphylactic shock or anaphylactic reaction. When do we call it as an anaphylactide reaction? You're taken in first dose of penicillin, that itself has caused you a shock. That means you are having an anaphylactide reaction, not an anaphylactic reaction, because you didn't had any prior exposure to this penicillin. The first exposure itself has led to a severe reaction.
Okay, thank you.
Doctor, in case of biphasic reaction in anaphylaxis, is there any treatment required or not?
Biphasic is similar treatment to that of anaphylaxis. So biphasic reaction is nothing but one more time you're having an anaphylactic reaction without the trigger. So first you had an anaphylaxis reaction, you're given IM adrenaline, he's completely back to the bed. Then you are kept him for observation. For example, after 3 hours, again, he might end up having an anaphylaxis. This anaphylaxis is termed as biphasic reaction, and it is treated similar to that of the anaphylaxis. There is no changes, similar algorithm you are following.
Sorry, Doctor, by means biphasic can suspect at least 2 hours after exposure for the first attack.
You need to, depending on this, minimum of 2 hours, you need to observe if they satisfy all this criteria. If not, if one of the criteria 6 hours, then if any one of this criteria, then 12 hours you need to observe.
Yani minimum observation 2 hours.
Minimum is 2 hours if they satisfy all this criteria.
Doctor, are there any particular substances that are more prone for a biphasic reaction?
Biphasic is difficult to say. Biphasic risk factors are this, according to the research website, and this is ALS and research.org website. These are the risk factors. They're not mentioned about any particular drug which might cause biphasic reaction or more prone to cause biphasic reactions. More common causes for anaphylaxis, they are mentioned about food and medications, what we have mentioned here.
Okay, thank you.
Sir, after biphasic reaction also the observation time would be same or different?
Observation time will be again, for example, you're admitted after 2 hours he had, then you'll be observing minimum of 12 hours again. So again, you're observing for minimum of 12 hours. So again, if you had, then again 12 hours is the minimum after a biphasic reaction you need to observe again.
Okay, thank you.
Coming to angioedema.
Refractory anaphylaxis and the biphasic anaphylaxis is same?
Treatment is same. There's no change. Biphasic or anaphylactoid or anaphylactic, all the treatments are same for all three conditions. Same algorithm we are following, there is no change. Coming to angioedema. Angioedema is nothing but severe form of urticaria. Severe form of urticaria is known as angioedema. In urticaria, only the superficial layer of the skin, epidermis, and mucosal membranes are involved. For example, here, usually urticaria is a raised erythematous rash. You see it like this. Okay, it might be in any part of the skin. Angioedema, usually the deeper layers are involved and there will be swelling, that is dermal, subcutaneous, and submucosal tissue will be involved. Most commonly, anatomical area which is involved is in the mouth, especially the lips, and tongues are the most commonly involved. Angioedema is broadly classified into allergic and non-allergic. Allergic is histamine mediated. Non-allergic is again classified into five different non-allergic. For example, a drug-induced. Drug-induced might be because of ACE inhibitors. Most of the time when we call it as a drug-induced, it will be an ACE inhibitor which is causing it. It is bradykinin mediated one. Heredity. Hereditarily, they have a gene which has a mutation which causes C1 esterase inhibitor deficiency. Remember that it is a C1 esterase inhibitor deficiency, not C1 esterase deficiency. Again, it is a bradykinin mediated one. Acquired one can happen due to chronic illnesses, especially due to autoimmune diseases like SLE, where autoantibodies are developed against C1 esterase inhibitor. So it is also an bradykinin mediated. Idiopathic, we don't know what the cause is itself. Pseudo-allergic are the other drugs. It's not only ACE inhibitors which causes angioedema. There are other drugs like NSAIDs also can cause angioedema. There are different other drugs like ACE inhibitors, vaccines, SSRIs, NSAIDs, statins, PPIs. All this can cause angioedema. What is the difference between an allergic angioedema and non-allergic angioedema and anaphylaxis? Anaphylaxis, we call it usually if there is more than two systems are involved. For example, the patient is having breathing difficulty and there is a rash and there is a low blood pressure. Minimum of two systems will be involved. Okay, then we call it as an anaphylaxis, and this is a severe condition. He will be hemodynamically unstable. So one of the parameters, at least either the SpO2 or the respiratory rate or the heart rate or the blood pressure or the GCS will be affected in anaphylaxis. In angioedema, there are two main different types we have discussed it. What is the main differences? In any angioedema will be anatomically localized, especially it will be localized to the lips and the tongue, basically the oral cavity around the face, it will be localized to. It will not be complete face, it will be around the mouth where the localization is. What is the difference between allergic and non-allergic? In allergic, it might be associated with an rash. That is an urticaria, raised erythematous urticarial rash, as you have seen in this image. If that image is absent, and usually this will be associated with itching. You will be having itching sensation, pruritus. Pruritus is absent in non-allergic. So look out for whether they have mentioned an itching or non-itching rash is present, then it goes more in favor of allergic angioedema. Non-allergic angioedema, there will be an abdominal pain, usually this patient will present with. Never in angioedema, the blood pressure will be affected. It is only affected in an anaphylaxis where you see an cardiovascular collapse. So grossly, cardiovascular or respiratory collapse or arrest, you see in anaphylaxis. That's the main difference between angioedema and anaphylaxis. When you are comparing an allergic and non-allergic angioedema, what you need to look out for is in allergic, there is a rash with itching. In non-allergic, the rash is absent. Usually it is associated with an abdominal pain. What is the treatment per se? If it is an allergic angioedema, moderate to severe attacks is treated with adrenaline. If it's a severe attack, for example, a tongue is swollen, there is an impending obstruction to the airway, then you give it an adrenaline without any delay. If there is not, it is a mild reaction, there is a mild swelling of the lips, mild swelling of the tongue, then you can think of giving these drugs. That is either an H1 receptor blockers like chlorpheniramine. You can give ensimetidine or ranitidine, which are H2 blockers. Steroids are given like prednisone. topical steroids are not recommended. They are of no value at all. What about hereditary or drug-induced or acquired angioedema? All these are bradykinin mediated one. So we need to give something to treat it. Either it is bradykinin 2 receptor antagonist, the preferred one, or you can give C1 esterase inhibitor concentrates. If both are not available, then you can give FFPs. FFP is a concentration of clotting factors. It also contains C1 esterase inhibitor also. That's the reason you can give them FFPs, transfuse FFPs. If it's an idiopathic or pseudo-allergen, it's a support you. Most of the time, they will not test you. They will test you either allergic or they'll be testing you hereditary or drug-induced angioedema in the exam. What is urticaria? Urticaria is a milder version of angioedema. If trigger is known, avoid the trigger, no matter how severe is the urticaria. In mild symptoms, we'll just avoid the trigger, no treatment is required. In moderate symptoms, that's when patient is complaining too much of itching, doctor, unable to tolerate, please give me something. Then you can plan to give a non-sedating antihistamines like loratadine, fexofenadate. Up to 6 weeks, you can prescribe them if required. If there are severe symptoms, the rash is all over the body, there is a severe itching is there, and the patient is not able to tolerate it in spite of giving antihistamines, then you can add oral steroids like prednisone 40 mg daily for 7 days, you can give it. The drugs which are safer to give in breastfeeding moms are loratadine or cetirizine, basically non-sedating antihistamines, second generation antihistamines. In pregnancy, you tend to avoid as much as possible. If at all you must give it, then you give loratadine, otherwise avoid it. The common drugs which causes urticaria are similar to that of anaphylaxis, like penicillin, aspirin, NSAIDs. Vaccinations can cause. Foods are especially the cow milk, eggs, peanuts, tree nuts, and shellfish can cause urticarial reaction. Okay, these are the common food substances which can trigger urticaria, more commonly known compared to other food substances and compared to other drugs. Any questions you have regarding angioedema or urticaria, you can ask me now before we get into recall questions.
So can you repeat the treatment of the angioedema, allergic and non-allergic?
Allergic angioedema is basically histamine mediated. Okay, because it is an histamine mediated, you can block the histamine receptors, that is H1 histamine receptor and H2 receptors. Along with it, you can also give an steroid. If it is in severe one, that's when you give an adrenaline, which acts much better than this receptor blockers. Okay. What about hereditary and drug-induced or acquired angioedema? This is bradykinin mediated one. Okay, it is not histamine mediated one. None of these drugs will be effective here. That's the reason we give supportive treatment is always required. Like if the patient is required oxygen, you'll be giving those supportive treatment, that is ABCD management you will be doing. Along with it, specific management here is either you're giving bradykinin 2 receptor antagonist, or you are giving C1 esterase inhibitor concentrate, or you are giving FFP. This is the specific treatment for hereditary or drug-induced or acquired angioedema. So it's clear?
Excuse me, Bob.
Yes, please.
If I may go back to anaphylaxis, can we say that the key point in symptoms that presents to hospital is hypertension? Most of other symptoms can be the one give you a clue for anaphylaxis?
See, it's not only the hypotension which you can consider as an anaphylaxis. Sometimes blood pressure might be maintained. So you need to look out for different systems here. There might be even nausea. GI system is also involved in anaphylaxis. There might be symptoms like nausea, vomiting, diarrhea. Along with it, breathing difficulty he might come up with. There might be a rash with breathing difficulty, or it might be a rash with hypotension. So there is a combination of different systems usually presents with. If you go through and internally and see, they have given a tabular form itself where different systems are involved with the systems. And in US, usually they label anaphylaxis if 2 systems are involved. For example, a respiratory and cardiovascular system is involved, a GI and cardiovascular system is involved. Then we usually label them as anaphylaxis. But any unstable patient, vital parameters, what you're checking, like an GCS, or you're checking for saturations, respiratory rate, heart rate, and blood pressure, any of this is significantly affected, then you call it or label them as anaphylaxis.
Okay, thank you.
Excuse me, sir.
Yes, please.
Sir, one of my relative died from the bee bite. Is there any investigation that we know before that we have allergy with bee?
Anaphylaxis is a clinical diagnosis. Only thing which can help you to support, you don't know what has happened, there is no history at all, and the patient has come in with, then you can get a muscle tryptase level. That's why we usually tend to get muscle tryptase level to label them. Yes, this is an anaphylaxis. I have the proof also here, because it's a clinical diagnosis. We are in the age of evidence-based. This gives you the evidence. Anyone has any other questions? Yes, please.
Yes, I have a question regarding the past slides of orbit score. It's written in success. Yes, orbit score. It's written in success. MR in success. That hemoglobin for men and women is 2 point, not 1 point, as you mentioned. So what is the difference between this and that? This is the first question.
So you're talking about the orbit score, which we discussed in cardiology chapter, and you're telling
in the latest chapter before this chart, صح? You must reassess the patient according to orbit score for high risk. Am I right?
We have not discussed orbit score in resuscitation chapter. Orbit score is high risk for bleeding, which we have discussed in cardiology chapter.
Okay.
Okay, we are not discussed in the resuscitation chapter at all.
Okay.
Dr. Amin, just can you mention urticaria to avoid what in pregnancy?
We avoid any drugs in pregnancy. In pregnancy, we avoid any drugs. Usually, we don't give any drugs in pregnancy, so we avoid antihistamine also. So we tend to avoid giving any drugs. If at all you are forced to give it, then you can give loratadine.
Dr. Amin,
the patient is having severe symptoms, severe itching is there, and they're really asking you for the medications, then you can prescribe loratadine. Otherwise, avoid for mild and moderate symptoms.
Dr. Amin, MRCM exam prep says that in pregnancy you can give alarmin. It's right or not?
Which drug, sorry?
Alarmin, chlorpheniramine.
According to NICE guidelines, November 2022, they advised to give loratadine. That's the only drug they have advised according to the NICE guidelines, November 2022. So we have taken this from the NICE guideline.
Sir, I have a question regarding the asthma treatment.
Asthma.
Yeah, if sir patient, asthmatic patient present to emergency department with tachycardia, so which drug you prefer apratropium or salbutamol?
Again, we'll discuss asthma in the respiratory chapter while we're coming across, okay?
Okay, sir.
Okay, usually tachycardia will be there. If it is not significant enough, we will go ahead with salbutamol.
Dr. Amin?
Yes, please.
Yes, if a severe symptom, will give add prednisolone with histamine also, with antihistamine?
Which one? Sorry, can you repeat?
In severe symptom of urticaria, will give prednisolone. You said
Yes,
add
yes.
prednisolone.
We can
Also
give
with
oral steroids
antihistamine?
like prednisone along with all these drugs, along with the antihistamine. So you're giving an antihistamine like a cetirizine. Along with cetirizine, you're giving prednisone.
Okay, thank you.
So we are getting into the previous year's recall questions. There are plenty of recall questions, so we have plenty of time to discuss now. Okay, I want all of you to contribute here so that we know what is your thought process. If required, we can do necessary, or if required, we can explain accordingly. So we have a 45-year-old gentleman here who presented unresponsive. Paramedics brought him here. There's no central pulse, so he's in cardiac arrest. CPR is started. One of the nurse checks the temperature and tells it is 28 degrees Celsius. So it is an hypothermia. So one of the reversible causes is hypothermia this patient is in. They're just asking what is the modification to the standard ALS guidelines. So which one of this following is correct?
Adrenaline to be given when
Option 2.
temperature more than 30.
Option 2.
Second one is right.
2 versus more than 30.
Option 2 is the correct one. Adrenaline to be given when the temperature is more than 30 degrees Celsius. Adrenaline is double the duration we are giving if the temperature is between 30 to 34 degrees Celsius. Adrenaline is given at regular intervals with regular dose when the temperature is more than 34 degrees Celsius. So we'll go for the next one. We have a patient who has presented to the ED with complaints of dizziness, denies any chest pain or syncope, similar complaints in past 2 days. They have given you the ECG here. What is the diagnosis on the ECG? Polymorphic VT is also known as torsades de pointes. So anything we can say.
Magnesium over sulfate.
Is this patient is having life-threatening features or not? Next question should be life-threatening features or no life-threatening features?
There is no.
No life-threatening features. So what is the management for polymorphic VT?
Magnesium. Magnesium.
Magnesium sulfate 2 grams, usually given over 15 to 20 minutes, will be the treatment here. We have a 12 kgs weighing kid in the cardiac arrest. Rhythm strip is shown this, showing this.
Asynchronous 50.
What is the dose you shock they are asking? So
for synchronized 50 joule.
4 milligram per
Asynchronized.
So it is 48 joules. As there is no
Option 1.
Synchronized 50
No,
joules.
option 4.
Just a minute.
Asynchronized.
Just a minute. Let me talk. Here the option,
50
right?
joules.
Option is asynchronized one. It is when patients are in cardiac arrest, it's always asynchronized, not in synchronized. When they are not in cardiac arrest, that means if the central pulse is felt, then you are giving an synchronized shock. When there is no central pulse, then you are giving an asynchronized shock. That means the patient is in cardiac arrest. You an asynchronized shock, 48 joules, so approximately 50 joules you can deliver to this patient.
Dr. Amin, this is not for children, just asynchronous shock, asynchronized shock?
It's for
Or
adults and pediatric, both.
For both?
Yes, for both adults and pediatrics, we always give an asynchronous shock in cardiac arrest.
Okay, thank you.
Next one is we have an elderly female who has presented with bradycardia. That is heart rate, what they are mentioned here. Heart rate is 35 beats per minute. Blood pressure is 85/60. Atropine 3 mg already given in divided doses. Noradrenaline infusion is already started. ECG is shown below. What is the next step they are asking?
External
Pacing. External
Option
pacing.
2.
Option 2 will be the right answer here. What if there was one more option as adrenaline infusion and they had not given this in the scenario? So which one will be right now?
Adrenaline infusion.
External pacing.
We will still choose external pacing because external pacing is preferred over adrenal or second line of drugs.
Okay.
We have an 80-year-old man who has presented, who has known case of hypertension, has taken Ramipril for many months. No new drugs recently been added. You see and tongue swelling here. What's the likely diagnosis? We know it's an angioedema.
AC inhibitor.
It's an ACE inhibitor. It might take few months to develop an angioedema or trigger. Okay, it doesn't mean it has to be an acute ingestion to have an angioedema. The patient, there are cases where they are mentioned patient was in ACE inhibitors for years together. Later on, they developed angioedema. So it doesn't depend on the duration.
Dr. Amin, please, last question. This for external pacing. Just 1 minute. When we will go for this admit her for permanent pacing?
When transcutaneous, you started on second line of drugs, you started on transcutaneous pacing. If still there is no rhythm or still the patient is symptomatic, the patient is bradycardic, then you'll be going for permanent pacing. If the patient permanent pacing, you'll always admit these patients, anyone, because they will eventually require, because they can revert back to the same symptoms unless there is a reversible cause.
Okay, thank you.
If there is no reversible cause and they are gone into a complete heart block or mouth disease type 2, they require a permanent pacing. So you admit all those patients, usually to bridge the permanent pacing and the intervention what you have done, they usually do a transvenous pacing, and usually when the cardiologist or the cath lab is free, they will take up for a permanent pacing. We have an 11 years old kid here brought to the ED who has collapsed at the home and weight is around 12 kgs. ECG is shown below. What is the initial treatment for him? The question is. So is this
Option 4.
This is a polymorphic VT. All of us know that this patient is decompensated or compensated.
Decompensated.
If the patient is decompensated, we give shock. So it is not in cardiac scenario, so it is synchronized, and the initial shock what we are giving is 1 joule per kg. Subsequent shocks, if required, the energy will be increased.
Sir, before giving shock for this patient, we have to
You need to do unconscious sedation before you give the shock.
Okay.
Conscious
Sir.
sedation is the best.
Sir, excuse me, patient collapse means we can't take a cardiac arrest, no?
It's just a collapse, it's not a cardiac arrest. Okay. If they say, they should mention there are no respiratory affairs or there are no signs of life or there is no central pulse, then you can consider it as a cardiac arrest. These are the things what you need to look out for in the stem of the question. It's just a collapse what he had is not in arrest.
So why not magnesium? There is polymorphic VTEC with life-threatening features.
Compensated. The
Ha,
kid is decompensated. If you come here, immediate synchronized cardioversion.
Okay.
So
a couple of questions back, it is 4 joules per kg, sir. This is 1 joules per kg, sir.
In cardiac arrest, it's 4 joules per kg. When the patient is not in cardiac arrest, it's 1 joule per kg. This ECG we have come across in, sorry, this ECG we have come across in ECG class. I think in second ECG class. So what's the diagnosis here on the ECG?
Non-sustained
or non-sustained.
Non-sustained polymorphic VT.
Yes, VTAC.
It is a non-sustained ventricular tachycardia. We call it by definition a non-sustained. If this we can call it as in PBC if it's only single one. If there are more than 3, we call it as a non-sustained polymorphic ventricular tachycardia. Here you can't follow the standard tachycardic algorithm because it's a non-sustained one. In between you're having a sinus rhythm. So what we do for this treatment, if you remember, we are treating an underlying cause. Here the patient is having hypomagnesemia, so we are just giving the magnesium. 99% of the time they'll be having an underlying cause. You need to just treat the underlying cause. We don't give a shock here, because if you give a shock here, he'll revert back to the sinus rhythm. After that, again, he'll be having an VT. So there is no point in shocking this patient. So
Sir,
D is not the correct answer. B is the correct answer.
Sir, what is you said? What is the difference between polymorphic non-sustained and the PVC? Sir?
It should be more than 3 consecutive PVCs. If you count here, there are 4. If you count here, I think there are 5. Then we call it as a non-sustained ventricular tachycardia. If there are only 2, then we can call it as an PVC. Or there is only 1, you call it as an premature ventricular contraction. We have a 30-year-old woman who has presented with a severe asthmatic attack, went into cardiac arrest during initial evaluation. Resuscitation started according to the ALS algorithm, supraglottic airway device in place. Which was the following? Which one of the following? Not was it? Which one of the following is correct out of the options given? Supraglottic airway will provide effective ventilation during ventilation. Supraglottic device is not preferred. It's endotracheal intubation what is preferred in asthmatic patients. Supraglottic airway device, because of the restrictive airway, obstructive airway disease, it can inflate, cause gastric inflation. Ventilation rate to be high? No. Ventilation rate should be around 10 beats per minute. If it's high, usually it predisposes to dynamic hyperinflation. IV magnesium sulfate is contraindicated? No, it is recommended in IV magnesium. We'll read more about treatment of asthma in coming up chapters. Bilateral pneumothorax can be ruled out using a chest X-ray? No, you can't rule out pneumothorax. Smaller pneumothorax X-ray is not sensitive enough to pick it up. Due to hyperinflation, higher energy of defibrillation might be required. Yes. This is the right answer because of hyperinflation. Air is in poor conduction of the current, so you might require an higher energies. So we have an 8-year-old child brought to the ET with history of collapse. ECG shows an SVT, treated accordingly. So nothing question related to this first phrase at all here. Here they are asking most common tachycardia in children.
Sinus
tachycardia is most common. If a child is crying, he might have a tachycardia. If child is in pain, he might have tachycardia. If a child is having fever, he can have tachycardia. So tachycardia is the most commonest. If they ask most common arrhythmia in children,
SVT.
In adults?
AF.
In adults, it's atrial fibrillation. In children, it's SVT if they're asking about arrhythmias. If they just ask tachycardia, sinus tachycardia is the most commonest one. We have a 22-year-old young female who has presented with palpitation. Nurse says she's struggling to take blood pressure because of high heart rate. ECG is taken, shown below. What is the mess step? So diagnosis on ECG?
SVT.
Supraventricular tachycardia, what this patient is having. Now the confusion is nurse is
Option A.
Nurse is struggling to measure blood pressure as the heart rate is high. Whether to consider this as the patient blood pressure is so low that the nurse is not able to take it, or the nurse is not competent enough to record the blood pressure because of high heart rate. Usually we consider all these nurses are ideal nurses, the best nurses we are having. That's why we will consider this is as a low blood pressure. That's why we'll go for an synchronized shock here. So clear?
But Dr. Amin, in previous that you said it's option A.
No, this is yes, adverse feature. Hypotension with SBT.
Hypotension is nothing but a shock. It's a life-threatening feature. So BP might be so low. Sorry, one of you, please.
I think so. Answer is well, Salva. Maybe there.
The main reason, I think in the Google Forms we are just wrongly marked it as Vasalva, but the similar question is there in MRChem success also, where they say go for synchronized shock. Usually, if nurse is struggling to measure blood pressure, we consider it as non-recordable blood pressure. That's the reason.
But Dr. Amin, in previous classes, last diet, you said nurse is struggling to measure BP. That means maybe BP is so high. That's why she cannot measure. And you said the answer is option A.
This is the main reason what we are changing is we kind of message or we kind of reply to the RChem, not RChem, sorry, MRCM success. MRChem success says we need to always consider the nurses who are there are the ideal nurses. If they are not able to record the blood pressure, that means you're not able to record the blood pressure. You can take it on the face value that if nurse is struggling means you're not able to record it. That's the main reason we are considering it as an blood pressure might be so low that she is not able to record it. That's the few parameters we are considering, and we are marking it as a synchronized shock. We are considering it might be a low blood pressure. But again, this is a confusing statement. It has only appeared in one diet. They are not repeated again. It might be very well that they might have deleted this question from the usually they delete few questions depending on the responses when they get it, or depending on the feedback what they get it from the students. So it might be one of those questions which they have deleted. That's why they're not repeating it. It has not repeated after this. There are 2 dates which has not appeared in the exam. For all purposes, we still recommend, or we recommend giving synchronized shock.
With an error criteria.
Yes,
What's about the extreme heart rate? Extreme heart rate, it is indication for shock?
No. Extreme heart rate is not an indication for shock. If we just look out for life-threatening features, we don't look out for extreme heart rate.
Dr. Amin?
Yes, please.
Sorry. In the same scenario, can you go back, please? Same question. Yes, same scenario, and the patient is have no adverse feature, and he is asking about the best next step. It will be Valsalva maneuver or IV adenosine?
It will be Valsalva maneuver. We
Yes,
have a
next
similar
step.
question. We'll discuss again. It's in Valsalva maneuver what we're talking about.
Okay, thank you.
Dr. Amin?
Yes, please.
Doctor, we had one question just few minutes ago about the polymorph VT, and patient is collapse, and you said synchronized shock. But according to AHA, American Heart Association tachycardic algorithm, only we can give synchronized shock to monomorph TVT, not a polymorph.
This is according, we are following ALS algorithm here, and it was in pediatric ALS algorithm what we are looking out for. So in pediatric, any broad complex tachycardia, so any VT, it is a polymorphic or non-polymorphic VT, we give and synchronized shock. So it is according, this is taken from the Resuscitation UK guidelines. So you need to follow the UK guidelines. Don't follow AHA, don't follow American guidelines.
Okay, thank you.
So we are coming for the next question. We have an elderly gentleman who has presented in the ambulance unresponsive, 12-lead ECG shows and 3rd-degree AV block. Heart rate is 34 per minute. Blood pressure is at the borderline. Patient has not responded for pacing. You decided to do transcutaneous pacing. So you decided to do a transcutaneous pacing and it is not responding. You reached to a current of 100 milliamperes. Still monitor shows no capture. What will be the next step they are asking?
Increase the current.
Increase
current.
current.
Up to 200.
So what you'll be doing here is you will increase the current. You can increase the current up to 1200 milliamperes. So you will be increasing the current here. That will be the right next step. We have an young child, 18 months old, choking, he's gasping and he's unresponsive. What is the next course of action here?
5 rescue breaths.
We give 5 rescue breaths. That will be the right step or right next step. There is an ongoing CPR here. Nurse asks you what is the recommended compressions over 1 minute.
100
to 120 is the recommendation. So we'll go for the next one here. Infant is brought to the ED. On examination, the temperature is high. Capillary refilling time is high. Less than 2 is the normal capillary refilling time. It is 4 seconds here. ECG is shown below. What is the next best step?
Paracetamol.
Shock.
It's adenosine.
In infants, if you go through the algorithm here, in infants, we call it SVT if the heart rate is more than 220.
220.
Here, if you see, approximately, it is approximately, I'm telling, I'm not calculating perfectly. It is 1.5 blocks, you can say. If the 300 divided by 1.5, it comes around, approximately, it comes around 200 odd. See, it more seems like because of high temperature, which is causing it. If at all, when you calculate it, which I'm not doing it here, it's time consuming. If you calculate and the heart rate comes more than 220, that's when you will be giving synchronized shock because this patient CRT is on the higher side. Otherwise, you'll be just giving paracetamol. Reduce the temperature. If the temperature is reduced, the heart rate will come down. So the answer depends on the heart rate here. If heart rate is more than 220, shock, synchronized shock, because this patient is having an decompensation. If it is less than 220, give paracetamol. Because of high temperature, give paracetamol. Clear? So always look for the heart rate. Usually in the exam itself, they will provide you the heart rate. So it will become easier for you to diagnose and easier for you to choose the option. If they're not given heart rate, then it becomes difficult. Then you need to calculate. That's when we recommend you to flag this, come back and calculate properly and choose the answer.
So if the heart rate is more than 220, then adenosine cannot be given.
Adenosine can be given if there is any delay in synchronized shock.
In Google Forms, answer
you can use synchronized shock.
Excuse me, sir. Regarding this question, the capillary refill time here question is more than 2 seconds. And the algorithm says when a patient is decompensated, the capillary refill time is more than 2 seconds. I think the patient is in a decompensated state.
More than 2 seconds decompensated. So we are coming to the SVT. Synchronized shock. Sorry. Synchronized shock, we give it if you can give it immediately. If there is any delay in synchronized shock, you can give adenosine. It depends on the heart rate. It's an infant what you are having here. If the heart rate is less than 20, just treat the underlying cause. So high temperature is causing it. Give the paracetamol, which will bring down the temperature. That will bring down the heart rate.
Doctor, I mean, this patient. Sorry.
But it's in sinus tachycardia. Doctor. The cause is in sinus tachycardia.
If less than 220, we'll consider it as in sinus tachycardia, because if the heart rate is around 200, 180 and all, P wave appreciation will become difficult. It usually overlaps the QRS complex.
But seems like it's SVT.
It seems like SVT, but in infants, you need to be very careful. That's the reason they have mentioned the heart rate here. In an adult, it is an SVT. No, you need not think twice before telling it is an SVT. In an infant, you need to think twice. That's the reason in algorithm also they have mentioned the heart rate here.
So, sir, whenever we see a
Doctor, I mean, sorry.
The pulse rate first before considering whether to give a synchronized cardioversion, adenosine, or just to lower the temperature, for example.
Yes, exactly. There's one more question you can ask me now.
Yeah. In this case also, this patient had a delayed capillary refill test 4. That means you said he's in decompensating on heart adverse pressure. He's in shock. Why priority for paracetamol to reduce temperature, in spite we should follow ABC approach and circulation became before disability? So why we didn't give him IV fluid?
You can give IV fluids, but you already have the cause here. You can give high temperature, then followed by IV fluids also can be given. But first of all, we assume that it's because of high temperature, bring down the temperature. At the same time, because of high temperature, there might be dehydration. You can give IV fluids also. Again, IV fluids will also be required. Paracetamol also will be required. Both will be required to bring down. But ideally, we'll be giving paracetamol followed by IV fluids. If you have one cannula itself, give IV paracetamol followed by IV fluids.
Okay.
So same scenario, temperature is not high, then
just give IV fluids. It might be because of the sepsis, because capillary refilling time is high. So it might be sepsis which is causing this.
Sir, this is sinus. Sir, this is sinus tachycardia, no? Not a SVT.
We need to very carefully calculate the heart rate here. If you see it from R to R interval, it is around, if I'm not wrong, 1.4. You can take it a large boxes. So 300 divided by 1.4. I need a calculator. I'm not good at math. So that will be the heart rate here. So accordingly, we'll be treating.
So it should be BWF above, sir?
It
Am I
should be
right?
more than 220 to call it as an SVT. Same ECG. If its heart rate is more than 220, synchronized shock.
So
Okay.
what's the option in this case? Right
It depends on the heart rate. I have not calculated. So if someone has a calculator, just calculate it. So depending on the heart rate, we'll choose the option. Either paracetamol or synchronized shock.
It's 214.
214.
214. So 214 we'll still consider as in sinus tachycardia, and then we can choose paracetamol. It's not more than 220. So ECG will be a little bit more obvious. Either it will be 1.5 large boxes. So it will be a little bit more obvious. So it will be a little bit more easier to calculate. Most of the time, and the students, what they have told is heart rate was mentioned in the scenario itself. So it was easy to pick it up and easy to give the treatment. Heart rate will be mentioned in the scenario most of the time in the exam. You need not calculate it from the ECG. So coming here, husband gets a pregnant lady to the emergency department. Lady delivers in ED and you notice baby is not crying and not breathing. What is the initial step in management of the newborn? They're asking about newborn.
Drive the baby. Option 2.
Right answer is dry the baby. You need to follow the algorithm in which you need to dry and wrap the baby in warm clothes. That's the first thing what you're supposed to do. We are having a pregnant lady who delivers in ED, baby not breathing, watch clock is started, baby dried, wrapped in clean clothes according to neonatal resuscitation. What is the next step they are asking?
Assess the color, tone, and reflex.
Assess color and tone and reflex.
So next step is to assess the tone, color, breathing, and heart rate. Those 4 parameters needs to be assessed. They just mentioned 3 parameters, but still it is the right answer or most appropriate answer out of all this. Is not shout for help anytime in neonatal resuscitation. Usually one person should be sufficient to resuscitate a neonate, if not 2. You need not require many people to resuscitate. If you see during deliveries, the neonatologist, usually a single neonatologist will resuscitate with the help of one nurse. That's the reason we don't usually call for help during neonatal resuscitation. We have a 2-year-old kid suddenly becomes breathless while playing with Legos. It's a toy named Legos. On arrival to the emergency department, kid is not responding, but central pulse is felt. What is the next step? Best next step here?
5 rescue breaths.
5 rescue breaths.
5 rescue breaths. It doesn't depend on central pulse is felt or not. If they're unresponsive, then we give 5 rescue breaths. Sorry. We have a 5-year-old kid who has come to the ED. He becomes distressed after eating. On examination, patient is having weak cry. What is the action or what's the
5 rescue breaths.
2.
Option 2.
Below 5. 5 bag blow, 5 abdominal.
The right answer here is 5 back blows and 5 abdominal thrust. Weak cry is nothing but weak cough. We can consider it as a weak cough. So according to the algorithm, we are going for 5 blows and 5 abdominal thrust. We go for 5 blows and 5 chest thrust if the age was less than 1 year. Yes. 5 rescue breaths if the same kid was unresponsive, then we go for 5 rescue breaths. So we have a patient in cardiac arrest whose temperature is 28 degrees Celsius. ECG is done, shows a non-shockable rhythm. When do you administer adrenaline? They're asking.
After
warming temperature 30.
Once the temperature is more than 30 degrees Celsius, you can start administering adrenaline. So we have a 10-year-old boy who was complaining of breathing difficulty, started when having dinner with his parents. Complaints of diffused erythematous rash, blood pressure is 50/40. He diagnosed as anaphylaxis. The adrenaline dose you will administer is, they're just asking the dose here.
Option 3.
Option 3.
1000.
Option 3, for adults, we use it 0.5 mg. For 6 months to 6 years, we use it 0.15 mg.
0.5.
Yes.
Scenario about a patient with anaphylactic reactions, vitals are stable, no signs of shock. What supports anaphylactic reaction opposed to the anaphylactic shock?
Option 4.
Option 4.
Prior exposure to antigen.
Anaphylactide, there is no exposure to the prior exposure to the antigen is required. We have an young female comes with palpitation, heart rate, that is pulse rate is 230 beats per minute. Other vital parameters are normal. What is the first step to manage him?
Vagal maneuver.
Vagal maneuver is the first step here because this patient doesn't have any life-threatening features, and it is a narrow complex tachycardia. So narrow complex regular tachycardia. So vagal maneuver will be the first step. Patient is in anaphylactic shock, already given 2 doses, 2 times adrenaline has been given, infusion has been touched. What's the meaning of biphasic shock? Meaning of biphasic shock, they're asking.
Relapse of shock after response.
After response.
Relapse of shock after responding. So he has come back to a normal self, then again he goes into shock. Then we call it as biphasic reaction. This patient has a history of hypertension, recently started a new medication. This is the picture given. So what will be the diagnosis?
Angioedema.
More specific, it's an allergic angioedema or non-allergic?
Non-allergic.
Non-allergic.
Medication.
Non-allergic.
Non-allergic.
It's bradykinin.
Drug-induced non-allergic. So treatment, if they ask directly the treatment?
Stop the
C1 and
medication and
C1 is space.
Bradykinin 2 receptor antagonist.
Yeah, we can give bradykinin agonist also, antagonist also, or we can give C1 esterase inhibitors also, or we can give FFP. So we are having a question where you have tried resuscitation, you tried your level best. What is the indication to stop the CPR? You're kind of getting exhausted, you want to stop the CPR. So what symptoms suggest, or which one is parameter you need to consider before you stop the CPR?
reversible CPR
Reversible causes
more than 20
or reversible causes.
E will be the most appropriate. So basically you'll be looking for the duration more than 20 minutes, no response to the interventions, persistently low ETCO2, cardiac standstill on USG. These are the 4 things what we really depend on to stop the CPR. Here 2 of the things are mentioned. So combination of 2 things, you can stop the CPR because you have already addressed all the reversible causes and the CPR is going on for 20 minutes. We have a collapsed patient. He is found in 3rd degree heart block. He is shocked clinically, that means hypertensive. Comments on pacing, below rhythm is shown on the monitor. So what will be the next best step? So what this rhythm shows, what is the inference on rhythm?
Capture beat.
No electric capture. So we will increase the pacing current here. So we'll keep increasing. There is a capture, both mechanical and electric capture is there. Then we stop the current at that point. So patient is immunologically unstable, complete heart block, 3 mg adrenaline already given, transfusion pacing started at 70 beats per minute, maximum current is already reached. What is the next best step they're asking?
Option B.
Change the pads to anterior posterior position. Good. In refractory anaphylaxis, patient still has stridor post 2 doses of IM adrenaline. What to do till adrenaline infusion is prepared? So you are already preparing adrenaline infusion. In the meantime, what
Option C. Option C.
In the meantime, keep repeating IM 0.5 mg adrenaline doses every 5 minutes. There is a facial swelling for 6 hours, getting worse progressively on amlodipine. This patient is recently started on ibuprofen and paracetamol. So most likely what this patient is having, diagnosis?
Non-allergic.
Non-allergic.
Stop medication.
It's just an articaria. It's a facial swelling they are having. Angioedema, most of the time, anatomically, it localizes to the oral cavity around the lips, tongues. It doesn't cause facial swelling commonly, I'm telling. It is just a normal allergic reaction, articaria, what this patient is having. He's not having an angioedema. Angioedema, they will describe it as lip swelling, tongue swelling, the difficulty in breathing, or drooling of the saliva the patient is having. that kind of features will be there in angioedema. This looks more like an allergic reaction and urticaria what this patient is having. We will stop the medication which is causing and just give an antihistamine.
Cetirizine.
Periton is a brand name. Usually they will not give Periton. Usually they will mention the generic name. Chlorpheniramine is the Periton is nothing but chlorpheniramine. So you can give any antihistamine, preferably second generation antihistamine like cetirizine, loratadine, fexofenadate are the preferred second generation non-sedative antihistamines.
Okay.
Sorry, doctor. I mean, in the previous question, that patient, if he had airway complication, يعني the priority will be for adrenaline nebulizer, صح? Correct in this one.
If this one has an airway involved, then definitely you'll go for adrenaline first.
Nebulizer. This no, not this one. The previous question. Sorry, this one. Yeah. Here in refractory anaphylaxis, this patient, he had airway complication. So the priority in this, when we will prepare adrenaline infusion, what we will do? It will be for adrenaline IM or adrenaline nebulizer.
Adrenaline IM or sorry?
Nebulizer. Adrenaline
Nebulizer, you're asking me. Adrenaline IM will take over the priority. We'll give adrenaline IM followed by nebulizer because it's a systemic. Nebulizer just acts on your bronchioles. You need to give something which enters in your system. It is all over your system. So you're overall treating. So adrenaline IM takes over the adrenaline nebs.
The first priority. Okay.
First
Thank
priority. Followed by
Yes.
you have 5 minutes to give another dose. Then you can start an adrenaline nebulization in between.
Okay. Thank you.
We have a patient who is presented with palpitations, heart rate is high, blood pressure is low. Once synchronized shock is already being given, heart rate and blood pressure remains the same. So what will be the next step?
Synchronize this.
Synchronize again.
Up to 3 shocks we can give. After 3rd shock, that's when you give amiodarone. After 4th shock, that's when you start infusion, amiodarone infusion. So we have sorry.
Okay. Amiodarone infusion after the 4th shock.
After the 4th shock, we'll be starting on amiodarone infusion. Then we can give the 5th shock. In a restaurant called paramedics, as the kid was choking, paramedics tried with bag blow, abdominal thrust. Right now, kid is in cardiac arrest. On bag mask ventilation, no chest rise is seen. No chest rise is seen on bag mask ventilation. Important point to be noted. Patient is desaturating. Paramedics mentioned that they have intubated the patient and visualized ET tube going down the vocal cords. This is the best method to confirm. This is the best method to confirm that ET tube is in situ, that is in the trachea, not in the esophagus. What is the next step they are asking here?
Tracheostomy.
Retract the tube to centimeter.
So what has happened? They have visualized the ET tube going inside. So the ET tube is gone in.
Tube 2 centimeter.
That's a wrong answer. Retracting. So what happened? This is the trachea what I have drawn here. This is the ET tube what I have drawn. ET tube has only reached till here. Okay. The foreign body is somewhere far away here. That's the reason you're not able to ventilate this patient. The chest rise is not seen because air is not passing beyond this level. So what you need to do is you need to get an access, that is tracheostomy. Tracheostomy is the preferred one here. You doing an ET tube suctioning here will not help you. Retracting 2 centimeters may not help you. In some conditions, pushing the ET tube beyond this level might help you. For example, here is the obstruction, here is the ET tube. You push the ET tube and this might go in one of the bronchioles here. Then you can ventilate one of the lungs. That is the other advanced management of foreign body in the trachea. You can see, but that option is not given here. So we'll go front of the neck axis, that is tracheostomy. We have a pulseless electrical activity cardiac arrest. Patient is intubated by paramedics. Anesthetic doctor, that is anesthesiologist, has confirmed that is in situ. IO access is in C2. What is the next step they are asking?
Or chest compression.
Option A.
Just do the chest compression. No matter what they say, first thing in cardiac arrest in adult patient is to start chest compression. That carries priority over everything else. There is an anaphylaxis and the site of adrenaline varied. There was a big scenario. We are cut down here. Site of injection of adrenaline they're asking.
Option A.
Option A is the right answer. You give it anterolateral part of the thigh. So option A is the right answer here. Oh, sorry. There is a penetrating trauma and the patient is in pulseless electrical activity. Ongoing CPR is there. E-fast is done, which is suggestive of an cardiac tamponade. What is the best next step?
B. Option B.
This patient is in cardiac arrest, so you need to do an thoracotomy. Thoracotomy is the preferred one. Blunt traumatic PA cardiac arrest, next best step.
Start CPR.
Start CPR is a similar question. Start CPR. We are into a neonatal resuscitation here. No chest rise is seen when you are giving 5 inflation breaths. What to do next, or what is the next best step here?
Start CPR.
Check mask and seal.
B. Check mask and seal.
This is the neonatal resuscitation. So you're checking for the mask seal here. Okay, this is a neonatal resuscitation. This is not an adult or pediatric resuscitation. Neonatal resuscitation, check for the mask seal. If that is not if that is not working, open the airway, use 2 persons technique. All those parameters you need to do. You need to have an 5 inflation breaths, that is chest rise needs to be seen. Proper breaths you need to give it. Patient presents with lip swelling, known to have similar complaints in the past, says that usual drug doesn't work. You give adrenaline, no response. Next step.
FFP.
FFP.
I have already marked here. FFP. Why not give C1 esterase concentrate?
Already given before.
Concentrate inhibitor.
It is the inhibitor which is the deficiency, not the C1 esterase itself. It's the inhibitor. Okay. So the right answer here is B.
FFP.
We have a 39 years old gentleman who has presented in cardiac arrest, ongoing CPR, core temperature is 28.3 degrees Celsius. Initial rhythm is VF, shock given. After 2 minutes, rhythm check shows again VF. What is the next step?
Shock.
Again shock.
Again shock.
Shock. Okay.
Shock. Is there already given 3 shocks then?
We'll stop shocking till 30.
Then wait for temperature to go to 30 degrees Celsius.
30, we'll start adrenaline.
Yes, that's right. 4th shock is given once the temperature is more than 30 degrees Celsius. So the next step here will be?
Don't shock till core temperature
give shock.
more than 30.
So this will be the right answer. Don't shock till the core temperature is next. Adrenaline, can we give adrenaline or can we give amiodarone? So what will be the next best step?
Give adrenaline for 6 to
Amiodarone. If after
No,
more than
amiodarone.
30,
Amiodarone
give
700 milligram. That's shock.
Amiodarone, because of the temperature, adrenaline because of the temperature is not recommended. Amiodarone still you can give after 3 shocks because you are following the standard ALS algorithm. They have not mentioned anything or any changes for the amiodarone. They have just mentioned the changes for adrenaline and shocks. So, but again, they usually love to test you on adrenaline and shocks because those are the changes. So remember those changes. Don't forget, one question for sure for hypothermia will appear in the exam. We have a 6 years old suddenly started choking while having food, brought to the ED unresponsive, central pulse felt. This is again repeat of the question what we have discussed.
Start CPR.
We start CPR. Ideally, it should have been 5 rescue breaths. As it is not mentioned, we are selecting start CPR here. There is an acute onset of rash, breathing difficulty. You suspect anaphylaxis. Given 1 dose of 0.5 mg adrenaline, no response. Next step. We repeat
Second
the
dose, adrenaline.
Indoors.
Second dose. Second dose is also not working. That's when you give adrenaline infusion. We have a 78 years old elderly chap who has come in with a high heart rate. BP is not recordable. You have this. So this is an SVT with life-threatening.
Synchronized shock.
So the right option will be synchronized shock. Patient with anaphylaxis, 1 dose of adrenaline already given, patient improved, was admitted in the CDU. CDU stands for Clinical Decision Unit. Okay. For observation, after 6 hours developed and similar symptoms. What is the next?
Adrenaline 0.5.
Second dose adrenaline 0.5 milligram IM.
Yes, this is a biphasic reaction what this patient is having, and the treatment is similar to that of the anaphylaxis. There is no difference, so you're treating as an anaphylaxis itself. There is no change at all. Preferred IOS insertion in children, we'll get back to this in procedures. We'll be discussing again in detail. Adults or in children's, preferred will remain proximal tibia. Second preferred sites in children, usually it will be humerus.
Lower
I think
part
in
of
adults it's humerus. I kind of forgot. Again, we'll be discussing in procedure chapters. Okay. This will discuss again in procedures. Here, the right answer is B. The second best option also you need to remember, which I'll be mentioning during our procedure class, which I don't remember as of now. Mom has bought to ED and a 2-year-old kid screaming. Baby is not responding. On assessment, there is no central buzz, no respiratory efforts. You start resuscitation. What is the adrenaline dose to be given in non-shockable rhythm?
1.2.
1.2.
So here they have given 2 kgs.
You
The
can
first thing
calculate it by
is
2 years.
calculate the
Medical weight.
This is the formula. So 2 into 2 plus 8. So it is 4 plus 8. So it is 12 kgs. For 12 kgs, you're giving per kg, you are giving, sorry, I'm sorry. The per kg, what you are giving is 0.1 ml per kg, what you are giving. So it will come up to 1.2 ml. The right answer is 1.2 ml of 1:10,000 dilution you are giving it. We have a 22 years old young lady who has come in with anaphylactic shock. Patient was self-administered adrenaline via EpiPen. Patient is currently asymptomatic, but you consider admission for observation. Which one of the following is a risk factor for biphasic reaction? They're asking just about the risk factor.
Previous history of anaphylaxis.
Previous history of biphasic reaction, not anaphylaxis.
Use adrenaline more than one time.
First one, use
Use of adrenaline more than one time is a risk factor for biphasic reaction. None of the following are. The other risk factors is severe presentation, delay in administration of adrenaline, history of previous biphasic reaction. We have a 60 years old male presented to the ED in ambulance with a syncope. Heart rate is 40, blood pressure is on the lower side. He's on regular medication, beta blockers. What is the next best step?
John.
Atropine.
He's on regular medication is beta blocker. It is not beta blocker overdose. If it is a beta blocker overdose, then glucagon will be the first option. If it is just a regular dose of the regular dose of beta blockers, what he is on, then you just give atropine as a first, followed by the second dose. You can start on second time you can give it as a glucagon. You can give first is always atropine. You have an elderly patient ongoing CPR. You go through the records. You find that the patient has a valid DNR that stands for do not resuscitate. Hence, resuscitation was stopped. How do you confirm death in cardiac arrest patient? Cardiac arrest itself is not death. They're asking how do you confirm?
Minimum of 5 minutes.
Right answer here is option 5. So you'll check for minimum 5 minutes, there should be absence of central pulse, heartbeat and respiratory efforts on auscultation. Then you can document as this patient is dead. You need to document the time, date, and you also need to document that you are checked for 5 minutes the central pulse, respiratory efforts, and you're also checked for respiratory breaths and heartbeat on auscultation. We have an 18 months old child unconscious while eating grapes. No air entry, unable to see chest raise on BVM stands for back wall mask ventilation. Next step they are asking here.
E, option
Open
E.
airway.
C.
Proper seal with
Option
mask.
C.
D.
Option E. E.
18 months.
Option C.
Ideally they should so rescue breath they are trying to give it using back mask ventilation. So if there is no chest raise, few things you need to consider before. Is the sealing good enough? If the sealing is not good of the mask, if the mask is not properly sealed, there might be air leak, which is that might be the reason there is no chest raise. There might be air leak from the mask itself because there is no proper seal. Next thing, still if it's not there, then you can use 2-person technique where one person is just trying to seal it properly, other person is just back masking. So the next best step here will be make sure that there is a proper seal. After that also, if there is no there is no chest raise at all, means you need to suspect somewhere the trachea is completely obstructing. You need to plan for front of neck access. But again, with CPR, chest compression, increased intrathoracic pressure, it might be expelled out. So cricothyroidotomy will not come immediately. It is a later step. So clear? Everyone agree? So we'll go for the next question here. We have an elderly male who has presented to the ED in ambulance, unresponsive. 12-lead ECG shows 3rd degree AV block. Heart rate is around 34 beats per minute. Blood pressure is at the borderline. Patient has not responded for pacing. You decide to do, and transcutaneous pacing is the same thing. You reached only 60 millimoles. Monitor shows no capture. What will be the next best step?
Increase current.
Current will be the right answer here.
Excuse me, so what's the maximum current?
200. Patient presents with palpitations, denies any chest pain or shortness of breath. On examination, patient is normotensive. ECG is shown below. Best next step they are asked. So what will be the
Magnesium sulfate.
5.
These are the questions which have appeared in last dates. Kind of repeat of the similar kind of questions where the dose was given here, dose was not given. Otherwise, very similar question which has repeated again. They say 3 doses of adrenaline given in a shock patient. What you will do next?
Adrenaline infusion.
The right answer is adrenaline infusion. They should have started after the 2nd dose itself, not after the 3rd dose. They should have ideally started after 2 doses itself. 3rd dose they have given, it's okay. Now you need to start adrenaline infusion.
So why not amiodarone?
Amiodarone, this is an anaphylactic. We don't use an amiodarone at all.
Yeah.
Ideal, doctor, after 2nd or 3rd dose?
Ideally after 2nd dose.
Infusion.
After second dose, you need to give it.
Or continue every 5 minutes until preparing an infusion.
Yes, that's right.
Okay.
6 months old baby bought 2. Again, here the heart rate is mentioned. So it is easy for you. So what's the diagnosis?
SVT.
Sinus tachycardia.
No, sinus tachycardia, if it is less than 220. More than 220 it is, so it is an SVT.
Very good.
What can be done here?
Adenosine.
Vagal maneuver.
We give adenosine.
Maneuver. First option, adenosine.
Shock is not given, so you choose adenosine. Adenosine, a drug can be given as an alternative to synchronized shock. So choose adenosine here. So they can.
Okay, why not vagal maneuver?
Why not vagal maneuver?
Pediatric. This is a pediatric.
This is decompensated.
No features of decompensated.
Just 1 second. Okay. Vehicle maneuver can be given here. Vehicle maneuver can be done here. Right.
Yes, it's vehicle maneuver.
Because there is no decompensated features.
Sorry, if there is a decompensated feature was given like CRT more than 2 seconds or anything like this was mentioned, then you would have considered of giving adenosine directly, as there was not mentioned adenosine will be the right option. Sorry, vagal maneuver will be the right option here, not adenosine. Okay, let me repeat it. This patient did not mention any decompensated features like an collapse or CRT more than or an hypotension. Nothing has been mentioned. That's the reason vagal maneuver will be the right answer here, not adenosine.
Doctor, I have a question.
Yes.
If CRT is more than 2 given, okay, then 2 seconds is given, then adenosine should be the right answer, right?
Yes, you are right. Then adenosine will be the right
answer. Over synchronous shock, or synchronous shock would be the first option, first choice.
If synchronized shock is given, then choose synchronized shock as first. If synchronized shock is not given, then you can choose adenosine.
Then adenosine. Okay. Thank you.
Yeah, as this patient is not decompensated, it is compensated SVT, then we are just doing an vagal maneuver. That will be the right answer here.
Okay. Thank you.
80 years old male who is known hypertensive on Remiprid for many years, no new drug recently, presents with swollen tongue as shown in the picture. What will be the right answer?
A. Option 1.
AC inhibitor.
Can be ruled out. Cannot be ruled out. It can be many years on Remiprid, still they can have an AC inhibitor induced angioedema. You cannot rule out angioedema, AC inhibitor angioedema, just because the duration is in years. Okay, it can be in years, still can cause an angioedema. So this is the picture given. So what you are suspecting here?
An allergic angioedema. Or drug induced, yes.
Airway is compromised. The tongue is so swollen that you are suspecting airway might be compromised. Can be still allergic angioedema. We are not sure. That's the reason the right answer here will be adrenaline IM. So we are thinking this picture, airway is compromised. There is nothing to suggest you of whether it is an allergic or non-allergic. We can really difficult to diagnose depending on that. We can assume that it might be an allergic angioedema. So we are giving adrenaline IM because it's a severe form, because tongue is quite swollen. You can see airway can compromise any point of time because of the tongue swelling. So it is a threatened airway. Airway might get compromised at any point of time. That's the reason we are giving adrenaline IM. It is a severe angioedema. So treat it with adrenaline.
Excuse me, boss. Even that there is a drug mentioned in the scenario, and as we know that angioedema cannot be mentioned previously.
See, drug is mentioned here. I do agree, but he is having a severe form of angioedema. Okay, severe form of angioedema. Drug is mentioned. It can be drug induced, but steroids and antihistamines will not act rapidly, so it will not be helpful, and there is no point. The steroids and antihistamines are given only in allergic, so it might. So we have a differential diagnosis. First differential diagnosis is drug induced. Second differential diagnosis is allergic induced angioedema. There is no treatment option given for drug induced angioedema. The treatment options what they are given are all allergic induced angioedema. So we can assume that this might be an allergic induced angioedema and it is in severe form. So we are preferring giving adrenaline over steroid and antihistamine. So it is clear?
Thank you. Thank you.
You're welcome. So we're going for the next question here. Sorry. Yeah, we have a 45 years old homeless male found on the street, unresponsive. Paramedics brought to him. It is a recall question which has appeared. The core temperature is here. Which one of the following is the correct? So which one is
Option B?
Option B. We have a 19 months old baby while having food suddenly turns blue in color. Panic mom brings to the ED. You notice baby is having seesaw respiration and unresponsive.
5 respiratories.
Doctor, what is seesaw respiration?
Seesaw respiration is where there is only abdominal muscles take over. So you can see abdomen is distending and compressing because there is diaphragmatic paralysis and all the other accessory muscles of respiration is not responding. That means he's going into an respiratory arrest. So basically this means he's impending respiratory arrest. Impending respiratory arrest. That's when you see seesaw respiration. Basically, he will go into arrest in next couple of minutes. We can expect in this scenarios. We have the last question here. We are not sure what exactly the question had come. This much we are able to get it. We have a 9-month-old child brought to the ED by mom. Complaints of a rash. Okay, says he is allergic to cow's milk. Last meal was 6 hours back. Mom has given paracetamol for fever 1 hour back. So this is the one image was given. Something similar type of rash was there on the image. Okay, what I got the feedback. Some similar kind of rash was there on the image. And they are asked, and these were the options given. They asked likely cause for this. We are not sure whether they had mentioned 6 hours back. They had.
Yeah, it was mentioned. Last meal was 6 hours back.
Exactly, it was same or something else was mentioned in the scenario.
It's the same.
No,
Last
it's
meal
the
was
same.
6 hours back. I can remember. It was the same.
Most likely it is still food induced.
Food induced, yes.
Food induced it is unlikely because of paracetamol. Paracetamol is one of the rarest causes. And usually arterial rashes will develop slowly. It will not be immediately. If you're seeing very acutely, it is seen in anaphylaxis. It can take few hours to develop, and sometimes it can take a day time also develop to have an arterial rash. Okay, food induced seems to be most appropriate options here. We're yet to find out from the feedbacks that whether this is the right answer or not. If someone has a feedback, can go through it and help it and put it in the group here, because we are not.
Yeah, I can remember the option. Last meal was 6 hours back. I can remember this very well because I was struggling to answer this question.
So you chose food induced?
Yeah, most probably.
Can you check your feedback and let us know whether you got the mark for that or not?
Okay, I'll let you know.
Okay, please post it in the group so that everyone is benefited, because this is a tricky question. It's very difficult to answer with only data what they have given. It's so much of data just to assume which is drug induced or food induced. It's difficult. Most probably food induced because whole milk is one of the commonest causes for allergy. So they might have ended giving cow's milk by mistake and ended up having this food induced allergic reaction.
Excuse me, sir. I think one of the recall questions, this question was repeated and the answer was acute viral fever.
It is very difficult to say it is because of acute viral fever itself. It can be because of acute viral fever also, but
due to the rash and the fever.
Due to rash and fever, it can be acute viral fever also. But again, whether there was an itching or not, all those things, if they are mentioned, then we will be able to pinpoint it. Usually in viral fever, there will be no itching involved. There will be only rash and fever. Then it can be an acute viral fever. But again, it's difficult to pinpoint it here. That's the reason we are not sure we are telling here.
Dr. Alamin, as I remember in last recall, this might be a viral infection. I mean, in the previous diet, not this diet, previous diet. So as I think this is a viral infection. So still we are confused.
Previous diet, it was not quite similar. They had not mentioned cow's milk. They had not mentioned last meal and all. They had just mentioned fever with rash, mumps comes, and they are shown a rash, and we had chosen acute viral fever because it fits in better. Here they have added a few more things. That question we'll be discussing again in other chapters. In dermatology, I think we are discussing that again. So it doesn't seem to be quite similar to that question, that recall question. That's the reason we are confused.
The picture
here.
was same. The picture was same.
Picture was same. Then it will be an acute viral fever itself. It will not be foot induced. It will be acute viral fever. They have just changed the scenario a little bit, I think, because last meal is 6 hours back, so unlikely. If the picture is same, it will be acute viral fever.
Dr. Amin, I have another recall question. I've a bit confused and I struggle during answer. I think you already discussed this question. The scenario was a patient brought to emergency by paramedics, history of blunt chest trauma during RTA. Paramedics continue CPR for 5 minutes during travel, but whenever they came to emergency, there is no pulse present. How you manage the patient? Continue CPR, give adrenaline bolus, clamshell thoracotomy, chest decompression, or needle pericardiocentesis?
Continue CPR.
Just continue CPR.
Okay, thank you.
Okay, and that is kind of twice or thrice we have gone through that question. It's continuous CPR. So this is the last question. If anyone has any doubts regarding the resuscitation, what you have covered over 2 days, can ask me now.
Sir, Karthik here.
Dr. Amin, the answer of the last question is viral fever, right?
One of you confirmed that it was a similar image, so the answer will be acute viral fever.
Sir, do we assume the
most
last
probably
meal?
the similar.
Sir, do we
So
assume the last meal was again cow's milk, or they just mentioned it as to confuse? So say
I've just mentioned it to confuse most probably, because last meal they have just mentioned mom might have not given, she might be extra careful and she must have not given cow's milk.
Yeah, it's last meal looks very far because
Last
in
meal,
physiology, gastric emptying and absorption take 4 hours. In physiology, gastric empty and absorption 4 hours. 6 hours looks
But
more
again, they
time.
have not mentioned when did the rash appear. Okay, but again, there is a fever history. Fever usually doesn't come with allergic reaction. Fever plus rash, we can call it as a viral fever. Viral xanthoma, what we call it as an viral xanthomas might present like an arterial rash. Usually we treat it similarly. We give antihistamines also because of release of antihistamines in viral fever can present a similar rash to that of the urticaria. So acute viral fever sounds more appropriate depending on this history, but food also can be there because one of you confirmed that it was a similar image to the recall question, then it will be an acute viral fever.
Doctor, in allergy or anaphylactic, there is no fevers, huh?
No, fever will not be there usually.
Food allergy can cause fever? Of course not, I think.
Fever
so we
usually
may
is not.
assume that because the mom knows that
It's
he's
most
allergic
likely
to
to
cow's
viral
milk.
fever.
So
Most
last
likely.
meal was not cow's milk. So it is just given last meal because we don't know it is cow's milk.
Yeah, that's right. They might have just given to confuse you. And then they have mentioned the fever 1 hour back and given paracetamol. They might have just confused you to choose food-induced one here. Or the drug-induced one, they have just confused you to choose one. It might be very well just an acute viral fever.
Sir, is there any typical pattern of rashes in a viral exanthem in children? Can we go?
It depends from viral infection to different viral infections. They'll have different patterns. So it doesn't present very typically.
So most probably we can take it as acute viral fever.
Most probably can take it as acute viral fever. Yes, that's right.
Thanks, sir. Thanks.
Anyone has any doubts regarding any algorithm, which step to go about, you can ask me. This is important. We are at least around 25 questions will appear from last 2 classes, today's and yesterday's class. Okay, it will not come anything outside this. This is the same thing. You can go and solve the questions in any question bank. You should be able to solve all the questions. I don't think any question you'll struggle to answer now. You should be able to answer all the questions. All the data, what is required, is being covered in last 2 classes. Any doubts? Anyone has any questions? Okay, we'll stop the class here. Thank you, everyone.
Thank you, boss.